Hi, everyone. Thank you for grabbing your seats. So hopefully you had a relaxing break, got some juices and some food to keep you going for the next hour and a half or so before lunch. With that, I guess it's hard to get a quiet room when you have kids. I need to start getting used to that. So I think this means decorum for we have everyone seated. And with that, it is my pleasure to introduce to you an 8P parent, Rebecca Pender, who has her own journey to share with all of us. She traveled all the way from Scotland to be with us, and she's the mother of 3 girls. Her eldest, Hannah, who's one of our 8P heroes, who's here with us this weekend. A little bit about Rebecca. Rebecca is involved with the internationally recognized program called Policy Making Program in Scotland, a leadership course for parents of disabled children and disabled self-advocates. When she's not doing that, she's writing in her own blog, so if you're not following her, to follow her blog, as well as guest writing on blogs such as Family Fund. In addition to writing, she speaks loudly and proudly about creating awareness for disabled children and advocating for them. She has spoken at the Scottish Parliament about the power of the parent and the power of the patient voice. With that, I'd like to call up Rebecca Pender to share her 8P journey with you all. Thank you.
I can't guarantee that I'm going to get through this without crying, so I apologise in advance. Most of you know me. We were all connected on Facebook, but for those that don't, I'm Rebecca, and I'm Hannah's mum. She's up here in the back corner. And yeah, I've got 3 girls, 2, 4, and 6, so it's a bit crazy in our house. Bina asked me to talk today about how much this project means to us, and in order to do that I need to take you back almost 7 years, tell you a little bit about our story, and why this project and our 8P family is so important to us, our community, and the future generations of families who are affected by 8P. It took 5 years of trying for us to conceive Hannah and finally fall pregnant with her, and I knew the second that I conceived her, long before any test could confirm it. The minute her cells started dividing and multiplying in my womb, I knew in my heart that I was carrying a child. Call it mother's instinct, a gut feeling, or something else, I just knew. And I shared it with my own mum, and I said, is it possible to just know? And she said, absolutely. So it really wasn't a surprise 2 weeks later when I called her and told her. And that sense of mother's instinct has served me well throughout our journey, and some of which I'll touch on today. So our first real challenge was convincing the medical professionals of our due date. So they placed my dates 18 days behind my own, an impossible decision, as it would have meant I fell pregnant after I'd got the positive pregnancy test. So I spent my entire pregnancy fighting a variety of people on my due date, until the end when someone believed me because she was measuring 43 weeks and 3 days and had little fluid left, and she was born 13 days late via induction. I was right. I spent the last hour of my labour telling them I needed to push, but they said I didn't. And as if to prove them wrong, Hannah crowned. I was right. She was silent, stunned, and misshapen, having spent so long in the birth canal. They cut the cord with speed, and the room filled as the midwife pulled the emergency button. And after what felt like an eternity, Hannah cried, the sweetest and quite possibly the most shrill sound I've ever heard in my life. Over the next few days, I was questioned a variety of different features she had that just didn't sit quite right with me. Her overlapped toes, her high shrill cry, her inability to latch or suckle, and a palmar crease on both hands and a sacral dimple. All of which was dismissed, there's nothing to see here. Over the next few months, we battled with reflux, extreme hypotonia and floppiness, colic, choking, and we fought so hard for smiles and laughs. I repeatedly raised my concerns with professionals about her development. All was dismissed, there's nothing to see here. I was told I was neurotic, I was sleep-deprived first-time mother. Stop comparing her with her peers, she's just lazy. After her first seizures at 13 months old, I was accused of Munchausen's by proxy. There was categorically nothing wrong with her. Maybe it was my own anxiety, and I was dismissed again. There's nothing to see here. Her inability to walk, crawl, babble, or hold her head up, dismissed. Eventually, when she was 18 months old, I had enough. I sought new medical professionals, I followed my gut, and I pushed hard to be believed, and I finally was. We all agreed that she probably had cerebral palsy from needing resuscitated at birth, but the protocol in the UK is to do a microarray test before the MRI to rule out anything genetic. And then I got the call. Hannah had induced L8P, and I was right. It was this really bizarre moment of duplicity. I was so relieved, as I'd fought so hard and it had paid off. And I was so scared because we were still so alone and there was no information. I was told it was rare. We don't know anything. Join Unique and they can help. So I downloaded the guide from their website and I read it through on the phone with my own mother who lives in Ireland. And we commented on how it had felt like they'd just spent 2 years with Hannah and written about her. It described everything perfectly, from her curly hair, her love of being upside down, and those eyebrows. But we were still alone. Until one evening I went into Facebook and I wondered what would happen if I typed induced L8P into a search bar. And I found a Facebook group. And I made a really tentative post introducing ourselves. And we were no longer alone. It felt like we came home. Oh, sorry. For it being so rare, there was all these people who suddenly had children that were a similar age to Hannah, and my God, they looked so alike. And again, those eyebrows, right? Most of our learning of induced L8P, what to expect, and what to try to help Hannah be the best version of herself that she can be, have come from our 8P family. We've been friends and family online for almost 5 years now, and I feel like I know you all as well as I know myself. You're our rocks when we have hard times and Hannah's in a hospital or we have concerns. We're a giant jigsaw of different nationalities and languages, and yet our 8P kids are the glue that hold us all together. Our journey made me realise that our story and battle to diagnosis is not actually rare, it's all too common. And regardless of diagnosis or geographic location, families are struggling to get a diagnosis or even be believed that they need help. So I'm active in the rare community, advocating for the power of the parent voice, trying to change the narrative so others have a different experience to what we did. This project is important because the more we research, the more information that we have, then the more families can walk this path without such a bumpy start. A family can approach their provider and the medical professional can say, I think this might actually be induced L8P. We stand on the shoulders of giants in the genetics field. With this study, the research team and all the families taking part, we become those giants. We pave the yellow brick road for every 8P family that walks behind us. We provide them with courage, knowledge, and most of all, love in knowing that they're not alone. Our community and our 8P family is one of the things in this world that I hold most dear. It's our silver lining in a journey that's tempestuous and unpredictable. The only thing that's constant and steady is the love, support, the sense of belonging, and the learning we receive from around the world from each and every one of you. The passion in this room for changing the narrative and creating the future is powerful, and my heartfelt thanks goes to Bina for having a vision and believing in where it could take us. You've got 63 families from around the world in this room all together. When we walked into that room last night, we had never, ever met a single induced L8P child face to face. And we met most of them in one hit. Which is why I cried the whole evening. And it's only the beginning for Project 8P, and I can't wait to see where it takes us, and thank you so much.
Thank you so much, Rebecca, for sharing that touching story. I'm not a parent yet, but I think all these stories just make me cry, so I'm standing in the back crying with all of you guys. It's just truly touching and amazing what you guys are doing together. And now kind of hearing the narratives, next up we have Dr. Segal and Dr. McBrien, who are going to share a little bit about the neurological effects of 8P. So basically everything that happens in the brain and what that means for your child. A little bit about Dr. Segal. She is a board-certified neurologist with special qualifications in child neurology. She's received her BA in chemistry in Brooklyn, City of New York. She then received her MD and PhD in neuroscience at Mount Sinai of Medicine, where her research was focused on the white matter changes in the brain in schizophrenia. So she is the master of the brain, basically. That's what I take from that. So ask her those hard questions like Bina said before, because this is really the time to learn and to challenge each other. And so Dr. Segal and Dr. McBrien are both joining us from New York Presbyterian. They are both specialists in pediatrics neurology. So with that, I would love to introduce Dr. Segal and Dr. McBrien. Thank you.
Hi, everyone. I think that's fine. I'm from Brooklyn, so I speak really loudly. But if you can't hear, raise your hand. So it's truly an honor and a pleasure to be here and to just witness what the power of parents can do. The power of parents who are passionate about their children, passionate about their children's care, and passionate about making a difference and changing the world of science and medicine as we know it. So this is so inspiring for me, and I thank you all for coming together for this, to Bina and her team who made this possible, and for having me here to talk to you guys today. So I'm going to be talking about the neurologic effects of 8P rearrangements. I'm not going to be addressing seizures. I'm going to leave that to Dr. McBrien, who's an epileptologist, and you'll hear more about soon. I am a general child neurologist, so I see pretty much everything from stroke to developmental delay to migraines, everything except for seizures. And one of my areas of special interest is neurogenetics. So as I'm going to mention later, many of the physicians in this room will only meet, or out of this room, will only meet perhaps one 8P child in their entire career, because this is rare. So as I think you've heard before, you are the experts. You live with this day in and day out, and this is a two-way conversation, you teaching us and us teaching you. So again, I thank you for being here and for having me here today. So before this project got started, which, as you know, one of the goals of the 8P project is to gather more data and to get a better understanding of what this condition actually entails. There were some previously published data about 8P, and we knew that there were several domains affected. Language skills, especially expressive language, more so than receptive language. So the ability to speak was more affected than the ability to understand. Motor skills, and that means gross motor, so walking, running, jumping, and also fine motor, things like zippers, buttons. Tone, which I'll talk about in a couple of minutes. Social skills, they're previously described, there's a fairly large percentage of of kids with 8P who are on the autism spectrum, and that can range from the most mild to more severe. And behaviors. ADHD has been described, aggression has been described in previously published data. The data were pretty sparse. There weren't that many papers published about this, and one of the, like I said before, the main goals of this particular project is to get more data, to get a better understanding of what is actually included in HP so that we can help figure out how to best treat these disorders. So I apologize if I repeat some of what you've already heard from Dr. Chung. The Project 8P findings, some of the cardinal findings in the neurologic domain are language delay, and as I said before, receptive language is better than expressive language. So what I think many of us have heard from parents is that, oh, we feel that our daughter or our son understands so much of what we say to them, and there's so much going on in there that they just can't give back to us. So that gives us some ideas of, well, how can we help with the language skills, the language development, which I'll get to later. Motor delay, so like I said before, gross motor and fine motor skills are delayed in almost all kids with 8P. Hypotonia, and you've heard this term, I'm sure you've all heard this term from your physicians, and I'll talk about what exactly it is and what exactly it isn't. motor planning, so the ability to do complex motor activities. So for example, climbing up the stairs. For most of us, you don't have to think about climbing the stairs. But if you want to break down what it actually takes to go up a flight of steps, there's a very complex sequence of movements that all have to be done in the right order. Sorry, you guys, the screen is blocking me for those over there. I'm loud but small. Social skills, like I said before, the autism spectrum disorders, and that there can be a very wide range. One of the interesting things that came out of the Project AP is that actually most kids with AP are very happy and sociable. So there is a subset on the autism spectrum, but many of you will tell us that your children love being around other kids, love being around other people, and love interacting. And that didn't really emerge from the previously published data. Cognitive delays, and that sort of encompasses all the other areas on the slide. Seizures, which I'll leave to Dr. McBride, you've heard a little bit about before, and sleep pattern alterations, from not being able to fall asleep to waking up multiple times during the night. And this is also, the sleep pattern alterations is not something that was really clearly understood before we started hearing from you. So tone. Many of you or all of you have heard from your doctors that your child has low tone. What exactly does that mean? And I tell this to neurology residents all the time. It's hard to wrap your brain around sometimes. Tone and strength are not the same thing. So sometimes I'll tell a parent that their child has low tone and they'll tell me, no, but he's so strong. And that's true. Strength is how much power and force your muscles exert when you're purposely using them. So if you're trying to kick your mom away from giving you Tylenol when you have fever, for example, that's your strength that's coming into play. Where tone is when your muscles are not being actively used, how stiff or floppy they are. And most kids with AP are floppy or low tone, hypotonia. So this here is a picture of a child with low tone. A child with normal tone, if you held them up like that under their chest, they would be able to hold their arms and legs out in a kind of a Superman pose, where babies with low tone kind of just flop over and make this U. And this is often the first sign in infants that there's something that needs to be investigated and something that might not be quite right. Hypertonia is the opposite. That's when kids get very stiff. Now, most of our children with AP, like I said, are low tone to start with. However, if you don't get appropriate therapies, that can become stiffness. Just from not using the muscles appropriately, they can develop hypertonia and spasticity, which is where the joints get stiff and don't move appropriately. Questions so far, or should I wait for questions at the end? Who's in charge? I guess we'll wait at the end. Mm-hmm. Do you want me to wait for questions at the end? Do you have questions?
I just had a question.
Sure.
Do you find that you said it was never noted before that the children are very very happy, sociable, that they love interacting? While they love interacting, do you find, or does anybody comment if they actually initiate the interaction?
That's
or
a good,
enjoy being around versus enjoying being around the interaction?
right. So I can tell you just anecdotal evidence. That's not something that has been investigated in a sort of comprehensive way. I don't know the answer. I think what we've heard from parents is that many children do actually initiate. They will come over and initiate. I don't know if anyone would like to speak to their experience as an AP parent.
Our daughter seeks out other children all the time. She's 7, and it's not a typical high wire, of course, but she'll touch, she'll reach out for other kids, she'll follow, or she'll find other children.
So she'll try to interact. Okay, yeah.
It can be very hard for kids who have limited or no expressive language to initiate
Right,
social
yeah,
interaction. So you have to sort of deduce from their behavior. Yeah.
I was just going to say, having a 25-year-old, up until she was probably in high school, she was more of the seeker. But the older she's gotten, and maybe part of it's because she's out of the school districts now because she's aged out and stuff, so she's not around people as much. But now she's very much, don't touch me. Even you can talk in a minute. Hush. And for you people that ask about speech and yeah. Anyway, but I mean, so that's one of the things I've noticed with her. Kind of the older she's gotten, now she's kind of gotten more of an aversion to people.
Yeah.
And she's like, "Don't look at me, don't touch me, don't talk to me." So I mean, whether that be from an issue we had 3 years ago when she was in the hospital for a long period of time, or if that would have, I mean, but even before then, I think she was probably about. Have to look back and see, 16 or 17, we revisited her genetics doctor, and he clinically diagnosed her with Cohen syndrome, which he said is often seen in the 8 chromosome 8 gene or whatever. And he said that so with Cohen syndrome, that's one of the things that was with it was like the aversion to touch. And so we were having issues at school because, you know, one of the teachers would touch her and she would holler at them. And so she was getting in trouble for it. And I'm like, well, then don't touch her.
Right.
You know? And
The logical next step.
so we went to him. And so, I mean, he actually put it in writing so I could take it to school and be like, so look now, don't touch her.
Right.
But I mean, so anyway, that's just
Right.
kind of what I've seen with her.
Yeah, I think there's probably a variety. I personally, I've heard that many children do initiate. Yeah, I think maybe just to make sure that everyone has the time to ask questions, I will save for the end, if that's okay with everyone. No, not at all. Thank you. And I like I said before, and you've heard before, one of the purposes of this conference is for us to hear from you what your experiences are, and this is so valuable for everyone. So MRI findings. Dr. Chung mentioned this briefly. Most kids not everyone who has an 8P rearrangement has had an MRI, and it isn't always medically necessary per se, but of the kids who've had MRIs, most are normal. Most are structurally normal. Of the rare or less common kids who have abnormalities on their MRI, we see the agenesis of the corpus callosum, either complete or partial, and I'll show you what that means, and sometimes a thin corpus callosum. Those are probably among the more common abnormalities that we find. The corpus callosum is the band of fibers that connects the two parts of the brain. So you have your left hemisphere and your right hemisphere, and they communicate to each other through the corpus callosum. Here, is a picture. This here is a normally developed brain, and this thick band here, this white kind of C over there, is the corpus callosum. So it's the highway that connects the two parts of the brain. This here is actually not an 8P child. It's a different patient of mine, but you can see that that thick band of tissue is not there. Okay? So the two halves of the brain are not communicating the way they should. In addition, I don't know if you can see it so well on your screen, but the corpus callosum becomes the bedrock of patterning for the rest of the brain. So here's that C, and then the other parts of the brain form, you see there's kind of a C above that. Can you see that? Where here, because that corpus callosum didn't form, the brain forms almost like the spokes of a wheel coming out from that midline. So it's not only the communication between the two halves of the brain that's affected, it's overall function of the brain as well. So what we see in kids who have problems with the corpus callosum, and again, this is not just AP, this is in the world of neurology at large, there tend to be problems with social communication. So they may, even kids who have normal language development, have trouble using their language in social situations. So they're not quite sure how to initiate conversation, or they can't quite follow a joke, for example. There are often problems with focus and attention, and there are problems with tone, usually hypotonia. All of these are things that we do see in 8P, even in children who don't have this agenesis of the corpus callosum, but in kids who do have corpus callosum abnormalities, that probably plays a role as well. Here's just another picture. This is looking from the top. So the previous picture was looking at from the side. This is looking from the top, kind of taking slices like this through the brain. And you can see here, this is a healthy, normally developed brain. These are the C kind of went around like that, and taking a cross section, these are the two bands of the corpus callosum. And in this brain, you see that there are no connections between the two of them. Now, I just want to mention in passing, you may have heard that hydrocephalus, or large ventricles, can be seen in 8P. So these here, you see this sort of like little apostrophe over there? Those are the ventricles. Those are fluid-filled spaces that help cushion the brain. This here is part of the ventricle of a kid without a corpus callosum. Do you see how this looks much larger than the ones on this side? So it's not actually from too much fluid
It's just, which is what hydrocephalus means, too much fluid causing pressure. When you don't have a corpus callosum, all the structures on either side of it form abnormally. So it can look like, hydrocephalus or enlarged ventricles, but it's actually not. It's just part of the same developmental problem. So this doesn't need neurosurgery. It doesn't need to be decompressed or anything like that. Okay, so it's just another picture, and you can see how large the ventricles can get, but this is not something that needs to be operated on. Okay, so those are some of the highlights of what we found from the AP project, what we're seeing from the neurologic angle. So, of course, as a physician, as a parent, the next question is, well, what can we do? We can't change the way the brain formed, right? It is what it is. So what can we do to help our children move forwards and to help compensate for the difficulties and the challenges that they face? So physical therapy is key. I believe you're going to be hearing later today or tomorrow from some therapists. It helps with helping kids catch up with their motor delay, the skills that they don't have. It helps sometimes, physical therapists can help kids learn new ways of achieving the same end results. So they might not be able to climb stairs the way your other children can, but they can learn other ways of patterning that movements to get around the motor planning issues. For kids with hypotonia, it's extremely important to have physical therapy to keep those muscles moving, because they might tend to want to just lay there. They might not be very active, and if you let them just lay there and not move their arms and legs, they will develop stiffness and stiffness of the joints. So to prevent that stiffness, that spasticity, physical therapy is key. Occupational therapists also can help with motor planning. They help with fine motor coordination, so teaching skills like zippers and buttons, eating with a fork, and sensory sensitivities, which some of your children may have. You know, they don't want their hair to be brushed, they don't want to wear certain clothing or choose certain textures, and occupational therapists can help relieve those sensory sensitivities. Speech therapy is key. Like I said before, many of our 8P kids have better understanding than they have expressing language. So nonverbal communication methods are important. This is a picture of a PEX board. That it used to be literally these laminated boards that kids would just point to what they want, but of course it's 2019, so now they have apps for that. You can get it on a very rugged iPad where kids can actually pick the pictures of what they want to what they're trying to communicate, whether something they want, something they need, something they're afraid of. And many children who have limited expressive language, they can't say, I need a drink, I want to use the bathroom, but they can find the pictures very easily and use that to communicate. So this is something that you should talk about with your speech therapist. Are there nonverbal communication methods that we can use to try to help? Should you consider brain imaging? So I said before, most kids with 8P have not had brain MRIs. If the diagnosis was made on the basis of a chromosome test, like you heard before, a microarray, many physicians won't go on to do an MRI to figure out why your child isn't walking or isn't rolling over, because they have the answer. When it comes to brain imaging, there are CAT scans you've probably heard of, and MRIs. CAT scan is not helpful in this disorder. It's a lot of radiation to expose a kid to, and it doesn't give you a very good quality imaging. If you're going to do imaging at all, it would be an MRI. There's no radiation, but the downside is that it's a long test. It's at minimum 20 to 40 minutes. So our children, the 8P children, would need to be sedated. Right? There's no way they're going to hold still for 40 minutes. So there's a trade-off there. It gives you a picture of what the brain looks like, but there are always risks of sedating somebody. MRIs will provide you structural information of how the brain formed and what it looks like, but it won't tell you anything about how the brain works. So many children with 8P and other neurologic disorders will have a brain that looks completely normal in the way it developed, but we know is not behaving the way a typically developed brain does. Right now, there's no actionable information based on the MRI. It gives us a much better understanding of 8P, but I can't say, oh, well, if your child has agenesis of the corpus callosum, you should do treatment A. And if your child doesn't have agenesis of the corpus callosum, you should do treatment B. That may be coming. I suspect it will be coming. And organizations like this help us learn, well, the children who have agenesis of the corpus callosum did really well using this method of physical therapy. So it's more information. Information is power, but if you're making that decision whether or not to have an MRI in your child, just know that it probably will not change what you're doing for them on a day-to-day basis right now. Something to keep in mind. EEG shows you the function of the brain. This is a picture of an EEG. lots of squiggly lines, and it helps us tell if a child has seizures, and I'm going to leave more discussion of that to Dr. McBrien. There are new imaging techniques that are coming down the road. Right now, these are all research-based. So depending where you live, you may or may not have access to this at all. These are imaging modalities that help us, again, learn more about the function of the brain beyond just what we can see with the structure. So functional MRI, you have a child or an adult lay in an MRI machine, have them do a task, whether identifying colors or counting dots, and take pictures of which areas of the brain are active when the child is doing those tasks. For most of our kids, this is not at all relevant because you have to be awake and cooperating with instructions while holding perfectly still in the MRI, which is hard even for adults. Diffusion tensor imaging is here. So this looks at the fiber pathways within the brain. So they can actually track, this is one fiber pathway right here, using a lot of technical details that I won't go into right now. They can pick a fiber, a major fiber bundle, and actually follow the way it travels through the brain. So we can tell, well, is the reason that our child isn't speaking because the motor areas for language are not well connected to the auditory areas where you understand speech, for example. Again, this is all research-based, but there is a lot of work being done understanding how pathways develop within the brain affect how a child can function. Resting state MRI, that's this here. So this is when a child could be sedated and not doing anything, looks at what parts of the brain are active together. So which parts of the brain seem to be connected. So to use a very kind of basic example, if this part of my brain is active together with this part of my brain all the time, that probably means that those two pieces are connected. Does that make sense? So this can be done on a sedated child, but again, it doesn't give us actionable information right now. However, the future is now, and this certainly could change. Okay, so what's the role of a neurologist? Mm-hmm. Sure. I'm going to do questions at the end. Yeah, that's okay. I only have like 2 more slides. So what is the role of a neurologist? What do I and my colleagues do when we take care of kids with AP and other chromosome disorders? We monitor development really carefully. We keep track of where your child is in terms of their fine motor, their gross motor, their language skills, their social interactions. We recommend appropriate therapies and make sure that they're getting those therapies at school. I often write letters fighting for more services for kids who were denied services by their school district. Having a diagnosis is helpful because you have a medical reason for needing those therapies, so you can often get them through insurance and you can have more ammunition to bring to your school district. We monitor and treat for seizures if they happen, and we learn from you as you learn from us. So when you're choosing a neurologist, what should you look for? I think it's important to choose someone who has experience with developmental disabilities, who knows, well, if I have a child with hypotonia, they need physical therapy and occupational therapy. It's nice to have a physician who has experience with rare diseases, but don't think you're going to find a neurologist who has 10 other kids with AP. It's not going to happen. Most of us will see maybe 1 AP kid in our entire careers. But if they have experience with other rare disorders, they can use that experience to help inform how they address your child and your rare, one of a kind child. It's great to have a physician who's open to collaboration with experts in the field. So if I have only ever seen 1 child with AP, but I know there's a physician in London who has 10 of them, if I'm open to emailing that physician and saying, hey, what are your experiences? What can you recommend for me? That will help me take care of your child. Someone who's willing to communicate with parents and other providers, setting up conference calls with schools, with therapists to make sure we are all on the same page and we know what the best pathway forward is for treating your child. Someone who keeps current in the latest research and the latest trials. If there's a clinical trial out there, you want to know and you want to make sure your physician knows as well. Someone who's open to trying new things, as long as it's safe. We're at the cutting edge of science and of medicine right now. So you want someone who's heard from other people on your Facebook group that therapy A is really helpful, sure, let's go for it. Let's give it a try, as long as it's safe. And someone who's willing to learn. And of course, most of all, someone who sees themselves as part of a team. You're part of the team, your child is part of the team, we're part of a team. We're all working together with the common goal of helping your child be the best AP kid that they can be. And that's it. Any questions?
I
we'll have Dr. McBrien.
So maybe while they pull up my talk, I can just say a few words. I'm very honored to be here today, and quite humbled by the experience to speak in front of a room full of experts on this disorder, of which I am not. I am, however, an experienced epileptologist, and predominantly my practice is centered around children with hard-to-treat, intractable epilepsy, and children with rare disorders or epilepsy as a complication of other neurological diseases. So I hope that I can add something, whether your child has seizures or may be at risk for seizures, to the discussion. And I plan on being here this afternoon where maybe you can educate me a little bit about what your children have been through with seizures, because although research is ongoing as part of this project, there really isn't a lot of published data about epilepsy in this disease. And so my approach is going to be a little bit more broad to sort of get everyone on the same page about what we think about when we meet a child with a seizure disorder and how we try to approach it. This one's fine, I think. How do I do it? So I have no disclosures, and the objectives of my talk are a little bit self-styled, so I hope it meets everyone's needs. I just want to go over the definition of epilepsy, review the basics of how we diagnose and approach treatment, and explore why good seizure control is important, especially in children, regardless of what the underlying cause is for their seizures. So a little bit of background. Who will go on to develop epilepsy? In many conditions, we know, for example, we will get a genetic diagnosis early for some kids who've presented with other neurological concerns, and have very high confidence that those children will go on to have seizures. For conditions like AP, we know that less, again, in part because we know less about the disease, and also because epilepsy is largely multifactorial. So in many cases, you may have a higher risk than another child because of the unique genetic changes that you have, but there are other factors at play as well. So overall, in the community, 4 to 10% of kids will have a seizure, we know that, and over a lifetime, about 1%, maybe a little bit more, will have epilepsy. When you have specific other issues, that rate is much higher. The rate for AP is really unknown, and is sort of a work in process for us to know. What isn't epilepsy? So we'll hear this a lot. My child had febrile seizures, they had Coxsackie, they had Fifth disease when they were a baby, they had a seizure. In general, if your child has normal neurological development and has a brief seizure with a high fever, that is febrile seizures, it is not epilepsy. I see so many families who have kids who are 6, 7, 9, their children keep having seizures and they say, but I don't have epilepsy, I have febrile seizures. So understanding that many children with epilepsy for lots of different reasons will have seizures provoked by being sick, being overheated, or having a febrile illness. Those differentiations are important to be recognized by a specialist, whether it's a child neurologist or an epileptologist, to be clear about what we're trying to manage. These are some other things that are not epilepsy. So here are some definitions. I won't languish on them too long, but over time what we've realized is there are better ways for us to predict which child who has a seizure will go on to keep having seizures. For the purpose of this discussion, there's 2 real factors that are important. One is your EEG, which Dr. Segal had a nice image of, normal, or does it show the characteristic changes that tell us your brain is more excitable than it should be and will go on to have seizures? And those are the spiky brain waves that were on that image. The other would be whether or not there is an underlying disorder that's known to have a high risk of going on to seizures. And I think this is where the research that's ongoing with this group is so important, so we can really understand what are the specific parts of the mutations that are associated, deletions, duplications, which areas are involved that are really conveying the risk. Is it that there's agenesis of the corpus callosum? Is there other structural abnormalities that are not so obvious that are actually what's putting the children at risk for epilepsy? So who should be treated? What is the risk? Again, this is some background. For people with a first-time seizure and a normal EEG, we do not generally treat because it's unlikely, although not impossible, that you will keep having seizures. For kids who have an abnormal EEG, as I said a few years ago, the recommendations changed. So if you have epileptiform activity on your EEG and you've had one seizure, that's usually enough for us to decide that you're at high risk for seizures, and we should add something to help prevent them. And then if you've had 2 or more seizures without provocation. So obviously if you're a diabetic and you take too much insulin and you have a seizure because your sugar's very low, you don't have epilepsy, even if that happens over and over because you're not managing your diabetes well. But if you have seizures on their own, which is either without fever after age 6 or even with febrile illnesses or other routine issues like being sleep deprived, getting Benadryl, any of those minor things that are associated would be considered 2 seizures and a reason to treat. So why is this important for rare diseases? Well, rare diseases are rare, and if you look over time, things that didn't have a definition have now gradually come to the front to be described as associated with epilepsy. So it's important for us to understand by sharing the information about our children, what is the risk. It's also important to understand prognosis. So again, from the limited information that is available about AP, but also about other rare diseases, not every child is the same. So just because your child presents with epilepsy, how that will progress, what are the chances of outgrowing it, what are the chances that your child will respond to the first meds treated, are not clear. And this is where sharing that data is so important to the clinician who, as we've mentioned before, may only take care of one child with this disease. And then refining the best treatment. So I'm going to talk a little bit about the general approach to how we decide what medicine to pick, but the hope is that over time we'll know what are the best 2 medicines to pick if your child presents as an infant with epilepsy or as an older child or with a specific type of seizure when they present. And so here are a few examples that are also rare diseases, but are now well defined. So I've listed a few. One is the SCN1A mutation, which is associated with Dravet. Another rare disorder, but is extremely commonly associated with epilepsy of very variable types. So when the disease was first described by Charlotte Dravet, we thought that this was an epilepsy that only affected very young babies very severely. We now realize that different mutations in the same gene confer different risks for epilepsy over the lifespan, from febrile seizures that persist into older adulthood to other different complicated forms of epilepsy. But additionally, what we were able to learn, first by describing the group of children who were similar in the way they presented and their EEG features, and then identifying the gene, was that specific medications work better than others, and that there are other medical risks. So I think that that's why families banding together to bring their kids together and investigate is so important for advancing child neurology and eventually doing better to take care of these kids. There's a few others that are mentioned here. GLUT1 deficiency. Your brain does not get any sugar because the transporter doesn't work. The treatment is ketogenic diet. You put children on that diet, the seizures stop. Those are point mutations. Obviously, AP is a bigger issue with larger deletions and duplications of many genes. But things like trisomy 21 or Down syndrome or ring chromosome 20 are things that we've realized over time carry complex risks. So these are useful to know. So this is just a little bit of a brief foray. What's the brain? It's made of many neurons that communicate and store the information, but lots of other different cells that help keep those brain cells healthy. All of these process information, send out information, become active or connected to other neurons over time as the brain grows and matures throughout childhood. And that balance of inactivity and activity is random, at least as we record it on a scalp EEG. It's not random, it's very organized, but it's not obvious. When the activity becomes too synchronous, which can happen for many reasons, whether it's because a specific transporter in the brain doesn't work properly, or because we scarred the brain because you fell and have a huge bruise on your brain, or because of other reasons we don't understand, a seizure can develop. So everybody over time in the wrong situation could have a seizure. Like I said, if your sugar is very low, if I drop you out of a building, if you get meningitis. But generally, for those of us who do not have epilepsy, we never reach that threshold. Many different factors can cause you to exceed that threshold. I'm just going to go back. And when you do that repeatedly for unprovoked reasons, you have epilepsy. So for example, if your brain is naturally excitable because there's too much glutamate around because your body doesn't change it over to a relaxatory chemical, you may have epilepsy. If your brain has a scar that allows the neurons, like an abnormal feedback circuit, to just talk to each other over and over and over again, you may have breakthrough seizures. And this is just sort of a very silly illustration. In fact, for kids with epilepsy, periodically, unless we raise the threshold by adding medications or other treatments to the mix, are going to break through and have seizures. So again, I think it's important to just go over what are the different types of seizures. Many of you will know this, but just for everybody's sake, we like to break things down into generalized seizures and focal. That nomenclature is changing, but the idea that everything in the brain is involved and at risk for generating a seizure versus that one area is involved is very important. There are different types of seizures. So most families will say, oh, well, my child doesn't have seizures, they just have jerks, or they just stare, or they have drop events. So those are all seizures in some cases. So we have special names for them. And when you meet with your neurologist, if your child has epilepsy, I find it's very important to make sure families are informed about what are we specifically calling a seizure. Why do we think the child is having the seizure? Is it a generalized process, or is there something focal that's causing it because the treatment may be different? And what's not a seizure? So for many children with developmental issues, they may do lots of funny things, from stimming or staring or becoming quiet or sleepy at unusual times of the day. It's important to explore those with your doctor if they're repeated and unprovoked, and we don't have another good explanation. Because seizures can be subtle, and identifying them and treating them can often bring benefit to the child's overall function when we find those subtle seizures that are happening frequently, if that's the case. So these are some other types. So why do we want to treat seizures? For kids that are walking, and ambulating, we want to prevent injury. Every year in my practice, I take care of kids who've fallen downstairs, who've burned themselves on the radiator, who've just fallen and injured and cut themselves, cut their face, knocked their teeth out. So it's important to treat kids who are ambulatory. We know, and I bring this up not because it's common, because it's important to talk about, kids with poorly controlled seizures, especially kids with developmental issues associated with it, are at risk for sudden unexplained death. That's not a particular concern with 8P. We don't know that particularly, but it is important to recognize, because often we do have families who feel that maybe the medicines are worse than the disease, and why are we adding medicines to treat? For kids who have convulsive events, especially who may be hypotonic, may not be able to protect their airway, may have other issues, it's important to recognize that there may be a small and unclear reason that seizures and uncontrolled seizures may predispose you to that. We know, for example, in some of the other genetic syndromes associated with epilepsy, like Dravet, that is a big issue. And one of the things that the parent organizations and specific Dravet organizations were able to unmask is why in that disorder is it more of a risk. So I think that this is where sharing information and knowing what happens over time is important, so we can find those rare but important things associated with different genetic disorders. And then what I'd like to focus on most is the preventing of further developmental regression and decline associated with seizures. So when we approach management, we want to know, can we be specific about a diagnosis? Can we better understand if the epilepsy will be associated with other regression? And can we predict what's best for a child? And I think probably it's accurate to say at this point that for 8P, we can't be very specific about any of those things. By watching kids closely after they present and prioritizing how we're going to pick a treatment, we can start to decide if there may be a risk. So frequent seizures can be associated with a loss or regression of milestones or a delay in development, both because of the seizures, as well as for things that we can't see without putting an EEG on, which is the very frequent spiking that some children will have. The brain is doing important things even when it's not seizing, and we know that when much of the background is taken up in sleep and or in wakefulness by these abnormal brain waves that are not seizure, that are just a sign of how excitable the brain is, the areas involved are not doing what they're supposed to be doing. And that in many cases, if we can dramatically improve the burden of seizures for kids who do have frequent seizures, or improve the background activity, we can see an improvement in tone, alertness, cognition, and function. So whenever we have a child with developmental issues, especially if they are known to have seizures, who have a sudden regression or loss of skills without explanation, it's very important to take another look at a prolonged EEG and see if we're missing something. Some of the classic symptoms are things like infantile spasms, Dravet syndrome, which we talked about, Lennox-Gastaut, and ESES. The ones starred are really things that are broad and possible for many different disorders. So these are final common pathways that some children will develop because of their risk for seizures at specific times in life. So infantile spasms happen in early infancy. The spasms are brief. They're a small jerk, they happen in clusters, but it's actually the activity that you don't see that's happening all the time as this epilepsy presents that leads to the regression and loss of skills. An older syndrome in toddlerhood is Lennox-Gastaut syndrome, where you see many different types of seizures, as well as the bad background, which seizure control may not predict, and if children are not developing along the developmental trajectory they already had, it's important to look and see if we're seeing the unrecognized seizure activity in the background. And then the last one I think is probably the most important one because it's probably the least understood, but more common, is this electrical status epilepticus of sleep, which is basically just lots and lots of epileptiform discharges that are not an actual seizure, but happen almost every second of sleep and get in the way of normal brain functioning during sleep and are very well associated with regression and delay. And when we are able to fix that by adjusting medications, which we're not always able to do, we often do see an improvement in development. So how do we control or decrease seizures? Lots of different ways. I put the scariest one up first, but mostly because it shouldn't be so scary, which is surgery. So for kids whose seizures are very hard to treat, we've failed different medications, they're happening frequently, there are different neurostimulatory devices like VNS, calosotomy, so we know that kids with AP may have agenesis of the corpus callosum for kids that have frequent convulsions. Sometimes making that disconnection for them after can be helpful. Those are never first choices. Some other things, because I do run the diet program here, I like to mention are things like ketogenic diet, which is a high-fat, almost completely restricted carbohydrate diet, and other versions of it. We don't entirely understand how that works, but we know from the time of ancient Greece that fasting in patients with epilepsy will improve seizure control. That's both because ketone bodies have a neurorelaxatory effect like Diastat or Ativan does, but also because being in ketosis modulates cell membranes and other neurohormonal interactions that over time may lead to sustained improvement in seizure control. And then medicine. Other things that obviously families try to control are a lot. Some of them there's evidence for. So getting good sleep is important. We know being sleep deprived is often a big trigger, whether you have children who are very impaired with lots of seizures or very high functioning people who live a typical lifestyle. Taking your medications on time. So it's important to talk with your doctor about what's feasible. Can you keep the schedule they want, or will the school refuse to give a midday dose? Are you traveling a lot, and how will you take your medicines with you so that you can give a dose at 6 when you're not normally in the household? Being regular about the administration is important. And then tracking obvious triggers. So if you know, for example, that around the time of menstruation you're going to break through, there may be reasons for that related to hormones on the brain, but there also may be reasons about the metabolism of your medicine. For example, lamotrigine levels are dropped when you're in certain stages of your cycle. So it's important that if you recognize a trigger, even if it seems unusual, that you keep track of that and share that with your doctor. Sometimes that informs the discussion, sometimes we're at a loss, but you are the best observer of your child, so that's the most important. And then how do we pick a seizure med? I'll go on in a minute, and I think I'm going to run out of time soon. But there are a lot to choose from. So the first were phenobarbital and phenytoin. Over time, we got several more. After 2000, this is our list, more are growing every day. For most kids with genetic epilepsies who don't have a specific channelopathy or mutation associated with their disease, almost any medicine could be picked. So how do we choose from that list? We want one medicine. We know that most kids, even kids with genetic associated epilepsy, will do well with their first medication. We want one that has the fewest side effects. So they'll tend to be a common few that neurologists will turn to in children, both on how easy they are to give as well as how well they're tolerated. And there are other factors. Again, people live in different parts of the world where things are available, cost, etc. Some kids do need more than one medicine, and it's important to be thoughtful about that. Many times I see kids who are on 3 or 4 or 5 medicines. None of them have been adjusted fully to try a higher dose. A higher dose on one medicine will always be a better choice than having 3 or 4 medicines at the same time. Just going on. So adverse reactions. When you start a new medicine, you want to keep track of what you're noticing at home. So common reactions as we increase or start a dose would be usually seen after the dose, so 30 to 90 minutes after, or a few days after an increase as the levels start to climb. Things like fatigue, nausea, refusing to eat, dizziness, more unsteady gait. For people who are verbal, double vision or jumpy eye movements may be a common side effect for many of our medicines. All of those are going to be more likely to be seen when you're on 3 medicines instead of just 1. So again, emphasizing it makes sense to try a medicine fully if it was a good choice before moving on to the next medicine. And then there are rare side effects, and you should always ask your doctor when you're started on a new medicine, what are the common things I should expect and be prepared for, and what are the rare side effects like a severe allergic reaction or a glaucoma, which rarely some of our medicines can cause. We all put into our account is what we're going to pick for the first medicine. What's easy to take? Is your child tube fed? Can they chew a tablet? What will dissolve well if we're going to try to crush it up and mix it in water? And not all of our medicines are kid-friendly, although I will say in the last 10 years we've really seen an expansion of what medicines have been trialed in children, trialed in complex kids, and are available in kid-friendly forms. You should also explore what the known and common interactions are. So for some of our kids who may have other endocrine issues or have very painful periods or on steroids for asthma or other breathing issues, there can be interactions. So you want to share any new medicine, especially if it's going to be a regular part of the child's regimen, with your neurologist. Some meds have good side effects that we want and help us with our management. So if kids are heavy, we don't want to add a medicine that's going to make you have a bigger appetite. If your child is failing to thrive and just barely taking in enough calories, we don't want to put you on Topamax, which is going to make you not want to eat. Some meds are more alerting, and that would be something like Lamictal, a common medicine that's often used. Some meds are sedating, like the benzodiazepines, like Onfi, which are commonly used. So if children are having trouble sleeping, we want to put our sedating meds at night or a bigger dose at night. If children are very sedated and we're moving on to next medicine, we want to probably pick one that's not sedating or may even be alerting. Just go through this. You know, blood levels are a help. They're not necessary, but for many of us, we do follow them, especially as we try to achieve full seizure control, evaluate if the children are taking it. Some of our kids are spitting them out. Sometimes we're doing the dosing wrong. We're doing it with meals. So why should we make a change? And I think probably the last 3 slides are the most important. If seizures are not well controlled, or if you're seeing persistent side effects, you need to talk to your neurologist. If we're seeing less benefit than we are seeing pain from a medicine, it's not the right choice, even if we're seizure-free. So it's important to talk about that with your neurologist and come together to make a plan on how we can safely transition to something else. Abruptly stopping seizure medicines is never safe and may provoke stronger seizures than have been experienced in the past. And it's important to be open to exploring what you're observing and whether or not that may be side effects from the medicine or other issues. For example, is the child snoring heavily? Could they have sleep apnea? That might not be from the medicine, that might be because of other reasons like low tone and large tonsils. So it's important to explore that with your doctor, and hopefully you have that kind of collaborative relationship with your physician to do that. Before you switch, we talked about maximize the medicine before you move on, eliminate medicines that have not brought benefit, and divide doses when there are side effects. Sometimes the total daily dose divided twice a day is not tolerated. There's nausea, there's dizziness. If we can divide it into a third dose, it may be tolerated. So if you've seen a big benefit in your child's seizures from that medicine before you move on, it may be worthwhile to look at other formulations or ways of giving it. Final tips, obviously, you should know about what you're putting in your child. So if you don't feel that the doctor has explained to you why we're using this medicine, what our goals are, when we would move on, you should make sure that you ask. You should keep track of both your seizures as well as the symptoms you think may be related to either seizures, the underlying neurological disorder, as well as the medicine, and let your doctors know. Obviously, remember to take your meds, whether it's alarms on your meds or pill boxes, and be an advocate for your child because you are the expert on your child. An informed parent is such a partner in helping take care of children with complex epilepsy. So I hope that was helpful.